This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
I'm going to talk a little bit about the work that the Australian Commission on Safety and Quality in Healthcare has done in this area. So I'll talk a little bit about the role of the Commission in terms of the Australian healthcare system, very briefly, I promise. And then I'll talk about the work that I did developing a background paper about end-of-life care in acute settings, which led to the development of a national consensus statement. The National Consensus Statement has provided us with a foundation to incorporate some actions around end-of-life care in the next version of the National Safety and Quality Health Service Standards. It seems very early to be talking about those things, given the current standards are only sort of 4 or 5 years old. The next version, though, will be out in 2019, probably. And you can imagine there's quite a lot of work to be done to get to 2019 from our perspective. So the role of the Commission really is about leading and coordinating national improvements in the safety and quality of healthcare in Australia. And the majority of the work that we do is really achieved through processes of consultation and collaboration, where we have a shared funding arrangement, so it means that we're half funded by the federal government, and the other half of our funding comes from all of the states and territories. So it really means that the work that we do really needs to be focused on areas that benefit from national coordination. We don't want to duplicate the work that the states are doing. It really is about where there is a need to look at things from the federal perspective. So nominally, the program that I work for is the Recognising and Responding to Clinical Deterioration program. That program was established in 2009. It had a focus on acute hospitals, on potentially preventable deterioration, and one of the sort of fundamental components of that program was the development of a national consensus statement that you heard about this morning related to recognising and responding to clinical deterioration. It's not our role as a national organisation to say how you need to implement things across every health service in Australia in a detailed way. It's about providing guidance about the bits that are necessary. But given the enormous span of health services in Australia, everything from tiny remote clinics staffed by nurses to huge tertiary hospitals with all of the whiz-bang technology you could possibly ask for, it's about really fining things down to what are the essential bits that everybody needs to be looking at. So the consensus statement really aimed to do that for recognising and responding to deterioration. And again, it provided a platform for the development of a national safety and quality standard about recognising and responding to deterioration, which is now mandatory for health services to be accredited against in part of that process of accreditation to keep the doors open. Very early in the life of the Recognising and Responding to Clinical Deterioration program, we became aware that there were issues around end-of-life care and issues about the safety and quality of the end-of-life care that Australians were getting. In recent years, as we've already heard this morning, there has been increasing evidence of the involvement of medical emergency teams in end-of-life care. And these kind of conversations are happening in emergent situations where the patient, the family and the treating doctor might be unable or unavailable to participate in decision-making. And questions were really starting to arise about what was happening to these sorts of patients who are irreversibly deteriorating in the course of their dying and not having the opportunity to participate in setting the direction of their own care. So that's how we came to start to think about the sort of care of people who were dying in acute hospital settings. We had capacity to start looking at these issues in late 2012, and we really needed to limit the scope of this work, so we limited it to settings where acute care is provided very early on, partly because of our limited capacity to do the work, but also because the effective levers that we have for change in the system at the moment are largely focused in the acute care space. The other reason really is that we know that about 50% of Australians die in acute care settings, so we felt very strongly that we needed to start where the bulk of people were dying and see what the issues were. We acknowledged very early, though, that there's a critical role played by community services and aged care facilities and general practices in providing better end-of-life care, and that those links are something that we all need to start to think about as we implement systems to improve end-of-life care. After I did a bit of initial work scanning the literature, it became very clear very quickly that there was a lack of robust evidence about end-of-life care in acute hospitals. And what evidence was available suggested that there were safety and quality issues that needed to be addressed, but it was really difficult to make an assessment of what was happening in Australia. There was a bit of literature from the intensive care field, from the sort of MET research, some stuff from palliative care, and a bit of stuff from oncology and haematology. But I don't know about you, but when I was working in hospitals, I encountered a lot of people dying in general medical wards, and there was really very little to tell us what was happening in those sorts of spaces. So that led us to the place where we thought we actually needed to go and talk to some people. So I ended up interviewing about 100 people in various forums, focus groups, one-on-one interviews, spoke to clinicians, to consumers, to health managers, executives, policy people, a whole range of people. And the findings of those interviews, we thematically analysed them and then combined them with the findings of the literature scan, and that led to the release of a background paper in August of 2013. So I'll spend the next few minutes relating a few of the findings of that work. The main thing that we found was this is an enormously complex problem. And some of the broad themes that arose were the issues of acute care itself, the focus very much on discharge, that rapid process of pushing patients through and getting them out. So it's much easier to investigate, diagnose, treat, discharge than it is to stop and think about whether that's the appropriate thing to be doing. There were a whole lot of issues around the specialist model of care. So we all talk about silos, we all talk about the need for better coordination and collaboration across teams, but we're still working in a system which is very firmly built around specialties. And that means that people become invested in treating single organs or single diseases rather than treating the whole patient. There were lots of communication issues that we identified, particularly in terms of the conversation, delivering bad news, issues around delivering consistent messages to patients and families. A lot of the consumers that we spoke about said, you know, even though they'd been living with cancer for 10 years, no one had ever mentioned death. So there were some issues with just not communicating. There were issues around the preponderance of junior staff in our large hospitals and the inadequate training in end-of-life care that they have, which is throughout the system. There was very much an attitude. I remember a quote from a registrar who said, well, really, we just aim to keep the patient alive till Tuesday when the consultant comes in. And that was pretty common sort of finding. There were a lack of options for authoritative decision-making after hours. So I think the MET is filling some of those gaps. It's much harder to find someone senior to make a decision to stop treatment than it is to just keep deferring the decision until the deterioration is so acute that the MET becomes involved. And then there was a whole lot of fear and denial and uncertainty. And it was very interesting to me that clinicians talk about patients' and families' fear, denial and uncertainty, but what came across very strongly was that clinicians personally experience fear, denial and uncertainty when it comes to thinking about end-of-life issues. So I'm going to show you a few of the quotes from the interviews that I did. I think these really speak much more clearly to the issues than I can. The nice summary at the top there, we deal with quality of life, we don't deal with quality of death, basically summarises the whole of the background paper. And I think that that is one of the most important issues at play here. If we don't measure things, then they don't matter. Michael DeVita this morning talked about the importance of measurement. And I think end-of-life care, it's a human experience, it's not a hard scientific experience, and we still haven't got good ways of measuring that experience. The focus of our systems have certainly been heavily focused on measuring the number of deaths, the preventability of deaths, that sort of blame and shame kind of culture. And we've really largely failed to account for the human experiences of dying. The other issues raised by the quotes on the slide really relate to the sort of system issues of silos and shift work and hierarchy that are safety and quality issues that are much broader than just end-of-life care, but become particularly acute, I think, for patients who are at the end of life. I think my favourite quote from all of the interviews that I did is the chaplain there, who said that sometimes patients know they're dying and they just hope that someone actually mentions it at some point. And I think that's just a tragic testament to the quality of our current system. You know, I think nurses too struggle with the issues of advocating for end-of-life care. You know, nurses don't have a perfect record of identifying patients at the end of life either, but certainly from the interviews that I did, they were much more closely involved in the day-to-day process of caring for a patient, and certainly felt very acutely that they were failing their patients if they couldn't advocate for better end-of-life care. There were a lot of issues around the conversation, so there was a heavy focus on the discussion of the conversation, which was very much in capital letters. And it seemed to be used as a bit of a catch-all term for conversations about anything to do with the end of life. So prognosis of a life-limiting disease, discussions about resuscitation, limitations of medical treatment, making a referral to specialist palliative care, shifting to a palliative approach, actually telling a family that their relative was dying now. And this was obviously seen as a really weighted issue, something that was time-consuming, really difficult, and potentially really risky. So a lot of people talked about the sort of fear of difficult families, of conflict and complaints. And I had a very interesting experience at a medical grand round that I went to talk about these issues, where there was nearly fisticuffs in the audience about whether this sort of fear of conflict with families was real or imagined. And some people felt very strongly that doctors remember the one conversation where it went really badly and not the 99 conversations where it went very well. So it's hard to quantify how real that fear really is. Similarly, the issues around the potential legal consequences of getting end-of-life care wrong, it's hard to know whether these are a real or imagined fear. The way that you have the conversation was highlighted as a really important concept in terms of the ability to reach consensus with patients and families about the right thing to do next. And there was a great emphasis on the need to offer a firm opinion on the right thing to do, rather than that kind of shopping list of all the things that are theoretically possible. But it was very much acknowledged that to have the conversation in the right way, you need to have training. And it was clear that this was lacking across the board. So even an intensive care fellow who'd been working in hospitals for 10 years said that he'd just had practically no training at all. So what I found really was that in Australia there's been a lot of investment, a lot of commitment and many successes around the space of end-of-life care. There's been some great work with advanced care planning, some really interesting models of care that were being developed in individual hospitals. But the systems weren't there to support consistent end-of-life care that met the needs of patients in a high quality and safe sort of way, and that there was no standardised approach in terms of delivering end-of-life care. So we felt that as a national organisation with a responsibility for coordinating safety and quality improvement at a national level, the issue of having no standardised approach to what should end-of-life care look like in an acute hospital was a space where we could add some value. So that led us to develop a national consensus statement about the essential elements for safe and high-quality end-of-life care. If anyone wants a copy, my friend Ben, who works with me, is somewhere at the back over there, very tall bloke. And he has got some hard copies if you want one. So the purpose of the consensus statement really is to set a standard. It's not a mandated standard, but to provide some guidance about what we think is important in terms of the provision of end-of-life care in Australian hospitals. And that was developed with a lot of input. We held an expert roundtable that involved a whole lot of different types of people. We did a very extensive consultation process. We went to all of the cities in Australia and talked to people face-to-face. We put it out for written submissions. There was a survey, so on and so forth. And that led to the development of the consensus statement, which is targeted at adults who are likely to die within the next 12 months. The audience is as you see there. Within the consensus statement, there is emphasis on the importance of acute services linking to non-acute services, to palliative care, to community providers, to aged care, and to general practitioners. We limited the scope to 12 months because it allows some room around the uncertainty of prognosis. We know that that's a big issue in terms of identifying who is actually dying. And it includes the care of patients who are dying from chronic disease or malignancies, but also the care of people who are dying from sudden events such as stroke or trauma, though it's acknowledged that some of the actions in the consensus statement are less applicable when the timeframes are condensed. A companion document is currently in draft, which is an adaptation of the original consensus statement, which will look at the care of children and young people at the end of life. And that will come out for consultation at the end of the year, or sort of in the second half of the year. The existing consensus statement sets out 15 guiding principles, which are really about the philosophy of care, and that's really about patient-centred, goal-directed care. And the emphasis on death and dying being human experiences, compassion, prevention of suffering, and the importance of giving people choices about their preferences for their care at the end of life. Then there are 10 essential elements within the consensus statement. So the first 5 of those are really related to the processes of clinical care, talk about the things like shared decision-making, the importance of teamwork, the importance of identifying clear goals for the episode of care, the use of triggers to identify when patients are in need of end-of-life care. So what those look like, I think, there's still a gap in terms of the research, in terms of validated triggers, but even if it's simply using things like the surprise question, would you be surprised if this patient died in this admission or within the next year, those sorts of simple triggers have some value here. And then there are some issues, then there is an element which is about responding to concern, and really what that is about is ensuring that there are systems so that clinicians can get help when they're concerned that a patient has end-of-life issues that are unresolved. And ideally, that help would exist outside of the MET or in parallel to the MET. Then there are 5 prerequisites that talk about the sort of organisational things that need to be in place to support clinical people to do the work that they need to do to better care for people at the end of life. So that looks at things like clinical governance and leadership. It looks at education and training and having a look at what's required for the clinicians who work in your service. It's about providing access to clinical supervision and support for the people who are providing end-of-life care, having systems to measure what you're doing, to look at the quality of end-of-life care rather than just the preventability of death. And then it looks at supporting systems, so making sure that things line up with other mandated requirements like the National Safety and Quality Standards. So where we're heading next is really looking at embedding the work that we've done so far around end-of-life care into the next version of the National Safety and Quality Health Service Standards. I think a number of people have talked about Standard 9 already this morning, which is the standard around recognising and responding to clinical deterioration. And in a session later, tomorrow, we'll have Matthew Anstey talking about the evaluation of Standard 9. And it's clear that having a standard that is mandated helps to push systems to be developed in health services. So I think if we can embed the work around end-of-life care into the standards, it gives us a very powerful lever to support health services to start looking at this as an issue that needs attention. So those draft standards are not available publicly at the moment, but they'll be out for a second round of consultation later this year. So that is coming. Part of the review of the standards, we have included some specific actions around end-of-life care, but we've also made some revisions to the existing standard around partnering with consumers to really emphasise the importance of shared decision-making as a process at the level of the patient-clinician interaction, and also emphasise the importance of early identification of substitute decision-makers, so hopefully you don't end up with a situation where you don't know who to talk to about end-of-life care issues if the patient's no longer able to speak to themselves. There's also a new standard being included in the revision, which is currently called comprehensive care. And really that whole standard distills many of the elements of what we learned from the end-of-life care work and talks about the importance of patient-centred, goal-directed care for every patient, not just patients at the end of life. So that's looking at the importance of things like coordination between teams and across teams. It talks about the importance of collaboration. It talks about the importance of identifying risk early and then linking that identification of risk to some action for the patient. The specific actions around end-of-life care are really reflective of what's in the consensus statement, so nothing surprising there. So that's really the summary. I think the work that we've done over the last 4 years has given us some opportunities to start talking about end-of-life care. It's a thing that has been snowballing over the years since that we've been doing this work. It's very interesting to see the number of policy organisations and so on who are starting to get into this space. And there's also been an amazing amount of work done by the states and territories to start putting systems in place to improve the end-of-life care that Australians are getting. So that's it. Thank you very much.